have Professor Sandra Eades to talk to us here today. There are few people in Australia whose time is so precious. As Sandra is a recognised leader, but also heavily committed across multiple spheres. Professor Eades is a young woman from Western Australia. She has a background of academic excellence and was the first Aboriginal person to have both a medical degree and a PhD, which she completed under Fiona Stanley. She's a brilliant scientist, and she combines this with an unerring commitment to Aboriginal and Torres Strait Islander health, as well as a profound sense of what matters and what doesn't, and what's right and what is wrong. I consider myself very honoured to be able to seek Sandra's opinion on these matters, which I do often. She's received multiple prizes and recognition for her achievements and work to date. She's been a New South Wales Woman of the Year. She's received a Deadly. She's also received the Medical Journal of Australia Prize for Excellence. So there are very few people, I think, who combine achievements across all of those fields. And I think often in our context, we prioritise this sort of miracle cure and the greatness of discovery. And I know that when I was an intern in this hospital and I said I wanted to go into epidemiology and population health, people were aghast. They said, well, why would anybody want to do that? It's full of people with beards and bad dress sense. I had a psychiatrist trying to talk me out of it. I did say I didn't realise that it was in the DSM-4 at that point. Although I understand the DSM-5 is quite broad, so perhaps it is under that now. In any case, I think that Sandra absolutely embodies the focusing on prevention, the focusing on the long haul, the focusing on the incremental gains, which genuinely contribute to improvements in health. And I think very few people are aware that from 1997 to 2010, there was a 41% drop in Aboriginal cardiovascular mortality, which is an enormous achievement. And it isn't due to a miracle cure. It's due to the efforts of those communities, the efforts of those people, those individuals, and the efforts of the health professionals and other people who support them. And I think that it's Sandra's vision and her emphasis on prevention and on what matters, which is contributing to those terrific achievements. So I'd like you to join me in welcoming her. I'm really looking forward to hearing her presentation.
Thank you, Emily, for that terrific welcome. I'd like to acknowledge the Ngunnawal people as well, the traditional owners of the land we're meeting on today, and pay my respects to their elders past and present. And to all of you here today, thank you for the invitation to attend your annual health research meeting, and especially this, your first Indigenous health session, I think. So I took the liberty of changing the title of my talk in the 2 months since I gave that title. And great to see Samantha Faulkner, whose talk I missed this morning because my plane was cancelled. But at least it wasn't like last week where I was at a meeting and got food poisoning, so so I'm here. It's really a wander through different stories and the importance of not just being great researchers and conducting good research, but focusing on translation, for want of a better word. It's just a single word that competes with commercialisation, I think, in terms of public good outcomes as opposed to commercial outcomes from medical research. So let's go. So I've got about 3 areas to cover, and I might have to rush a little bit on the last one, which is the unsolved problem. I wanted to start with a good news story, because so often we go to an Aboriginal health talk and they're bad news stories for all the right reasons. But let me start with a good news story. So I did my PhD at the Telethon Institute for Child Health Research in Perth with Fiona Stanley. She's surrounded by lots of amazing epidemiologists and other scientists who do terrific work. Carol Bauer is one of the you probably may have heard of Fiona Stanley, but I'm not sure many of you will have heard of Carol Bauer. She's the epidemiologist who does all of the birth defects research with Fiona. And one of the things she focused on whilst I was a young PhD student working at the Telethon Kids, as it's known now, was neural tube defects. And we discovered that the importance of folic acid in preventing neural tube defects. And unfortunately, the neural tube forms and closes very early in pregnancy, almost before women realise they're pregnant. Once this discovery was made, folic acid, which is important in red cell production, blood cell production, and the formation of a healthy neural tube. If it doesn't close at the top, you get anencephaly. If it doesn't close at the bottom, you get spina bifida. And so hopefully you have a normal, healthy baby without a neural tube defect. So we knew about folate, and there were wide-scale programs in Western Australia promoting the benefits of periconceptional folate use. And Carol followed up around this time and wanted to see the impact of those health promotion programs on reducing neural tube defects in the West Australian community. And as always, they looked at whether outcomes had improved for Aboriginal and non-Aboriginal babies. So in the case of SIDS, once we discovered that sleeping on the front or side increased your risk of SIDS, that message filtered through, and the SIDS rate, another great epidemiology success story, the rate of death from sudden infant death syndrome about halved, but it didn't drop for Aboriginal infants, and it was the major cause of death in the first year of life. So the gap, the inequality increased because of the difficulty with impact of that message getting through. So this looked like another situation where folate was discovered. If only women could take periconceptional folate use, the rate of neural tube defects would drop by, I think about 65% of cases were attributable. What we have here is up between over 20 years, from 1980 to 2000, the Indigenous cases of neural tube defects, you can see over the period didn't really drop very much, but you can see from the first period to the last, the number of cases of neural tube defects amongst non-Indigenous women dropped substantially, and the differential increased, so about 42% higher risk for Aboriginal women early on, and almost double the risk in the later period. My small cameo role at this time was we conducted a cohort study of urban Aboriginal infants, and we asked the Aboriginal women in our cohort study in Perth a question about whether they knew of the importance of folate in pregnancy, and 55% of the Aboriginal women said they were aware of the importance of folate. If you looked at teenagers, it was about 30% of teenagers who had a baby were aware. So about half women were aware, but they clearly weren't in a position or effectively responding to the health promotion campaigns and taking folate. But this is what happened over the longer term. Down the bottom, that's the rate of neural tube defects. We have these periods which are pre, a transitional period from 2007 to 2009, and 2010 to 2014 was the post period. So their follow-up epidemiology, their awareness that the inequalities had increased, had Carol Bauer and Fiona Stanley persist with thinking, how can we solve this problem? And then they took the lead of 3 other countries, and they knew that fortifying flour with folate was important because it meant that across the whole populations, whether you were very poor or very wealthy, your dietary intake of folate would increase, and that's what's happened. So we didn't get the first impact with the first public health intervention for those at most risk, but we did get the impact. These are the rates of neural tube defects for Aboriginal infants in Western Australia, and you can see that dramatic drop after fortifying flour with folate. So For all those people that say health research doesn't do anything to improve Aboriginal health, ask any one of those mothers who might have had a baby with a neural tube defect. And just remember Carol Bauer, possibly up there with a number of other unsung heroes in public health and epidemiology in Australia. That to me is over a 20 or 30 year period. Translation doesn't happen overnight always, but it can happen, and it doesn't happen the moment you publish your paper. It requires considerable follow-up action. Actually, on the plane to Perth last week, I sat near Mike Daub on the plane. He was the Director General of the WA Health Department, and I said, "Oh, what about the folate story? Isn't that wonderful for public health?" And he said, "Oh, you'll never guess the story behind that." He said, "I was working as the Director General of the Health Department, and the Minister for Health, Jim McGuinty, said to me, 'Mike, what can we do for public health that doesn't cost much?'" So he went away and he spoke to Carol and Fiona and said, "Jim's asked me this question, what can we do?" And they said to him, "Tell him to advocate for fortification of flour with folate." And there you go. So part of the science and part of the folklore of that public health story and its relationship to Aboriginal health. So don't publish your paper, keep plugging on for the next 30 years. And if you don't get it on day 1 or year 5 or year 10, keep pressing on for the translational impact of your research. The second example is, we don't have the impact yet, but is a piece of work that I've been involved in. Judy Simpson and I supervise Alison Gibbard, who's an Indigenous Health and Biostatistics PhD student at the University of Sydney. And we started with a large-scale data linkage project in West Australia, and we very quickly had a look at the data and thought, oh, they haven't linked the data properly. A lot of the birth registration records are missing. So we went back to the data linkage branch and said, you haven't linked the records. We're missing a lot of birth registration records. And the data linkage branch promptly said to us, no, they're not missing. And we said, how do you know they're not missing? Well, gradually they filter in over the years and there's a catch-up. So I said to Judy and Alison, maybe we should have a look. It wasn't a question we set out to answer, but maybe we should have a look and sort out who's missing out on getting their birth registered and why, and what implications there are for policy and practice. And I had heard anecdotally in Western Australia, I had at least one cousin who had kids whose births weren't registered, and I started to hear stories about how difficult it was for them when they became teenagers. They wanted to get a driver's license, they wanted to get an 18 plus card to get into clubs, they wanted to join a sporting club, and then I thought, hell, they probably want a bank account and a passport, all the things that we take for granted. And then I thought about the mental health, all of the issues in Aboriginal adolescent mental health, and I thought, geez, how would it be if you were adolescent, Aboriginal, poor, and you realised your birth wasn't registered? It would really add to that feeling that you don't really count and you don't matter. So we did have a look, and I thought it's probably about 5% of births, but we'll see what's happening and if we can publish something that might help with policy. So the paperwork's, it's a state secret getting your birth registered, because really it's a check on who becomes Australian citizens and who doesn't. So you only get one form, you get it given to you at the hospital at which you're born, and it's supplied to you by to the parents by the hospital midwives. It must be lodged within 60 days of birth. Registration is free, but if you want a birth certificate, you have to pay $44. So in my mind, I thought, oh, what about some of those Aboriginal mothers who go home to their house, which might be overcrowded, with a lot of other people living there who are also poor, or they don't have a home, they go home to somebody else's house if they're staying with a relative. And if they lose that form, what happens to their kids? Or if, with all the chaos, they lose that form, it's very hard to actually replace that form. So in this study, we looked at births that were registered in, this is previous work, which also hints at a problem, of births registered in 2012, where the person was at least 6 years old at the time. among all Australians, there's about 1% of 6-year-olds without a birth registration. Amongst all Aboriginal Australians, about 8% in ABS data, and amongst all Aboriginal West Australians, about 15%. So in our data, we wanted to look at what factors associated with birth registrations for babies born to Aboriginal mothers in Western Australia. So there's a bunch of Aboriginal babies born to Aboriginal fathers, not in this data, because that wasn't possible to look at those babies as well. So we had data from the midwives notification source, birth registration records, family connection system, which links child to their mother, inpatient hospital records, which provided insurance, hospital, alcohol, drug, mental health data, and outpatient mental health records. So the outcome of interest was no birth registration by 2012, the latest full year for when our data was extracted, and the population was those babies born in WA from 1980 to 2010 with an Aboriginal mother. So Model 1 just looked at the registration rates over the whole time period from 1980 to 2010, and Model 2 looked restricted, so that's the oldest people in the data set were up to 30 years of age. And then we looked at children under 16 years of age who were dependent on somebody else to register their birth or help them get their birth registered. And we looked at factors associated with whether or not their birth had been registered. And in that second model, we adjusted for baby's year of birth, remoteness, socioeconomic disadvantage, and other maternal characteristics in the hospital category of birth. So there were 49, almost 50,000 Aboriginal children born during that period and in the data set, and we found that overall over 5,000 did not link to a birth registration. So about double what I originally thought, 5%, was actually just over 10%. But when you actually looked at children under 16, it was actually 18%. So almost 1 in 5 Aboriginal children, dependent or adolescents, dependent on somebody else to help them register their birth or register their birth, didn't have their birth registered. And this line varies. This is the year of birth, so the people born in 1980, 80 earlier, 30 years old, and these are the rates of registration for the oldest children later in the data set who are 2 years of age. And the overall rate for under 16, as I said, was less than, was 18%. So it really, in the in the models, it looked as if under registration, only looking at 50,000 odd births to Aboriginal mothers, no Aboriginal mothers in the study, it was really related to remoteness and poverty. And poverty is relative when you've got 50,000 births to a relatively impoverished population. But you can see the only thing predicting higher rates of registration were if your mother had private health insurance. If we looked at maternal age, which interacted with smoking status, you can see that generally in both models, the younger the mother was at the younger her age at the time she first gave birth to a baby, the higher the risk that she was not able to register her baby. And you can imagine that part of the chaos and the disadvantage that is part of this story might be more so for teenage mothers, but it gradually reduced the older and more experience she got with parenting and managing not just the social and health related but administrative parts of being a parent. Although among mothers who smoked, it was actually in the other direction. Older mothers who smoked had a higher odds ratio for an unregistered baby. If the mother herself was unregistered, she was almost 4 times less likely to register her baby. And you can see the relationship with remoteness, with remote and very remote communities, with the issues related, I guess, to distance from services, having a baby in another location and then taking you and your form back to the remote location that you usually live, and then a gradient with socioeconomic status as well, and alcohol use during the index pregnancy. So what did we do with this? Well, we wanted to publish it. So this is actually just another part, which was the hospital category. You can see a decline in the green line for babies in the rates of unregistered birth in the later periods for babies born in rural hospitals, and for babies born in tertiary hospitals, but an increase over the whole time period for public metropolitan and public private metropolitan hospitals. So you can see large numbers of Aboriginal children have no birth registration. It's more common in disadvantaged, remote and young families, and children born into disadvantage face further difficulties proving their identity. There's some increase in birth registrations in recent years, but further changes to the registration process may further increase the registration of all newborns, not just those, especially those with greater disadvantage. So we wanted to publish the paper. We didn't really have a translational strategy, but we sort of stumbled into one because the media people at our institute said, "Are you publishing any papers this year? Is there anything that's potentially of interest to the media?" And I said, "Oh, I don't know. We've found that almost 20% of Aboriginal babies born over 30 years in WA don't have a birth registration. It might sort of a human rights and health issue." And they said, "Yes, we'll have it." But we did also present the research to relevant groups of Aboriginal people in Western Australia, and it didn't really, nobody was excited as us. It didn't really have the impact. You know, that's terrible. What are we going to do about this? It was, you know, my poor PhD student, more just, you know, being ravaged for publishing a descriptive paper. But I thought it was important. So once we had a media strategy going, we also presented the results to the director of the local Aboriginal Health Service, and we said, we've got a media campaign. We don't want to be the spokesperson. We think there should be someone local in your community who helps speak about the importance of this in the media, and they joined with us. Then we had ongoing discussion and advocacy. Unfortunately, the paper was published in the Australian New Zealand Journal of Public Health at the beginning of NAIDOC week this year, Monday. And what Monday was that? That was the Monday after the federal election. So it's not a good day for a media release. But we worked with what we had, and we had a fabulous media strategy. So Monday morning, we didn't get on any of the major TV shows, and we didn't get in the Age, the Sydney Morning Herald or the Australian. We had written an editorial for the Australian, but they canned it because it was full of post-election news. But I've got to say, what I've learned from this is radio. Radio is amazing. You don't need to get into print media. I woke up, we did pre-recorded radiograms, which our media unit had arranged, and then they had also they hadn't arranged the live interviews, but we had some requests for live radio interviews. So we woke up on Monday morning to ABC Radio National News, and it was the sound of my voice, or alternating with the sound of my PhD student's voice. But we got like a short grab on that, and ABC Radio National News had asked the WA government for comment, and they were waiting on their response. We did long interviews with ABC radio, local radio in Perth, and we did a longish interview, about 7 or 8 minutes, which is long for radio, with 6PR in Perth, which is a common radio news. We got picked up by 2GB and syndicate through their syndicated other radio news. Got very wide coverage through New South Wales and we got picked up by SBS Online News in the Indigenous section, which meant lots of Indigenous people who trawl online news picked it up. And I think the real big breaker was being, when the Australian didn't pick up the editorial, we offered it to the Conversation and they picked it up. And the Conversation makes available their articles freely available throughout Australia and internationally. So I think because of the Conversation, we got picked up by The Guardian, the Daily Mail in Japan, Thomson Reuters, and it just sort of filtered through. With all the online news, we got quite a lot of Twitter posts and Facebooks and reposting. So even though it was the Monday after the federal election, our story got very wide coverage and very wide debate, and it really is a major human rights and health issue. And then within 48 hours, we got an email from the West Australian government requesting a copy of our paper because for the purpose of using this to suggest changes to government policy to increase birth registrations. So sometimes you think you just have a run-of-the-mill paper or and you just need to get it out and get it published. But it's worth thinking, if you have a good media team, thinking about the potential implications and trying to press on with getting some level of media coverage for it. So we're hopeful that in the future we'll be able to show further improvements in the birth registration rates in West Australia, but also in other states and territories, because it really is internationally an important human rights and health issue. So I want to skip on to cardiovascular disease, and I know Emily told you about those really impressive drops in the rates of death from cardiovascular disease for Indigenous Australians, but we're not quite there yet, and we still have a long way to go. So in the next 10 or 20 years, for as long as I'm in medical research, what I hope to see, and I think this one will be a bit tricky. I thought fixing and reducing neural tube defects was going to be difficult because of all the impediments to getting those rates down for Aboriginal babies. And I thought birth registrations wasn't on that scale and how could that change? But I'm hopeful now that that will change. But the brave new frontier for everybody, I think, because this is central to reducing the gap in Aboriginal health status, is cardiovascular disease. And I'll have a quick look. I have to say I'm also passionate about this because in the last couple of months I've dealt with my 55-year-old brother. He thought he was fit because he plays football. He goes, I'm a 55-year-old, I'm playing football, I'm healthy. He didn't know what his cholesterol was, he didn't know what his blood pressure was, he didn't smoke, but he lived with his partner he'd been married to for 25 years, and she smoked, so he was effectively a smoker because she smoked inside. And he stopped in his tracks about 6 or 8 weeks ago with chest pain and felt like he just couldn't breathe, came off the football field. And so over the next, my sister's a nurse, over the next 4 or 5 weeks, he went for a stress test, he had a positive stress test, he saw a cardiologist who said, you don't need an angiogram, you can be medically managed. So he got put on all the medical management. He had the shock of going from I'm a fit Aboriginal man to I'm not a fit, I'm not a healthy Aboriginal man, and the emotional transition. But then he also had to deal with the healthcare system because his symptoms didn't settle. Over the 4 or 5 weeks, they gradually worsened on treatment. He got to the point where my sister would say, I'm in Melbourne, they're in Perth. You know, he's getting that shortness of breath and chest tiredness. Now, when he vacuums his hallway or he takes his bins out and feels like he's fainting. And she said, I told him, go to the hospital to ED, you'll get sorted. So he saw 3 GPs, a cardiologist and the emergency department, and he wasn't offered an angiogram. And so I tried all these strategies over 4 or 5 weeks, and then eventually got through. He had an angiogram and a coronary artery bypass grafts within 2 weeks. But those are the personal stories behind the data, and I think fixing access to good cardiovascular care is not just an issue for Aboriginal people, it's an issue for people in rural communities, and it's an issue for people in areas with higher social disadvantage in Australia. And it's tricky because it's connected to economics and inequality and ability to pay, because you know there would be recent papers in the MJA showing that one of the things that having an angiogram is very strongly correlated to is whether or not you've got private health insurance. But fixing this will require a sort of economics, health inequality, health literacy on the part of my brother, cultural competence on the part of the healthcare system. So it's going to be interesting to see how we fix this and what the cut-through solution is. It won't be as easy as fortifying flour, I think, but I'm pretty sure there are a range of cut-through strategies. So the IHOPE study, these are data on cardiovascular disease from the IHOPE study in New South Wales, and they just reinforce the importance of this area and making progress with improving every level of care for cardiovascular disease, prevention, early diagnosis and treatment. This is another big data study. There were over 7 million people in this study with almost 33,000 different hospital records. It used New South Wales admitted patient data from July 2000 to March 2014. We also had fact of death and more recently cause of death data. The data is still answering questions, but one of the earliest issues we looked at was cardiovascular disease. But Louisa Jorm, Deb Randall and other collaborators now at the University of New South Wales are using it to look at these other range of problems, road traffic injuries. But let me skip through. Multi-level models are very good for looking at area level, clustered data, area level, family level data, and it's particularly useful for Aboriginal health because of the geographic distribution of Aboriginal people in New South Wales and the fact that 40% of Aboriginal people live in major cities compared with 70% of non-Aboriginal people. So it's different because you can fit a number of different regression lines to different areas and not just accept one average slope. And you can also accept different strengths of relationships in different areas, so the slope can also vary. So we first looked at the characteristics of Aboriginal people with heart attacks admitted to hospital with an AMI in New South Wales. So the average age of Aboriginal people was lower, like my brother was about 54, 55 years of age, more than 10 years younger than the average age of non-Aboriginal people. There were more smokers, less private health insurance, more likely to live in most disadvantaged areas, and less likely to have their first admission to a major city hospital, and less likely to be admitted to a hospital with specialist cardiac facilities. And the incidence rate for age standardised incidence rate for AMI was about double that for non-Aboriginal people, and an Aboriginal person had twice the risk of an AMI as a non-Aboriginal person in our study, a non-Aboriginal person of the same age, sex, year of event, and nicely in this study from the same area of residence. So we were kind of comparing people in northern New South Wales to people in northern New South Wales, not the data very nicely showed that. We were able to look at AMI incidence rates and the disparity for Aboriginal and non-Aboriginal people, and we showed that the greatest disparity was in younger age groups and for females. So the females on the right, males on the left, and you can see these very wide disparities for both sexes, but more so for females at younger ages. New South Wales Health was a big partner, and as Louisa Jorm said recently when presenting these data, policymakers love maps, so they could map where the rates were highest for Aboriginal people down to statistical local area, and the areas with higher rates were generally in regional and rural areas. And you can see that Canberra shows up as a white spot on these data, but Canberra has, I think, now joined New South Wales, and the ACT data is part of the New South Wales data linkage system, so future research will be able to show how the ACT compares to regions in New South Wales. So we could map where are the rates highest for Aboriginal people. We could map where are the high disparity areas for Aboriginal people. So in what regions do Aboriginal people have a much higher incidence compared to non-Aboriginal people in those regions? And we could also map the high incidence, high disparity areas. And you can see that they're similar but different. And so all of this work has really helped New South Wales Health think about, not just for Aboriginal people, but rural people, where the disparities are across the whole of the state in terms of AMI incidence and the distribution of facilities. So we then looked at disparity and revascularisation rates, and other people have looked at Aboriginal rates for angiography and various revascularisation procedures. But in this study, we originally found that if you're an Aboriginal person who's had an AMI, within the first 30 days after your AMI, you have a 37% lower revascularisation rate compared to a non-Aboriginal person the same age as you, the same sex, the same year of admission and the same AMI type. So so there's a gap. We tried to unpack what is the gap and what are the implications of that for policy. And I'll quickly whip through this, but there was variation between hospitals. So we looked at the hospital effect. If you took into account the hospital at which a person was first admitted with their AMI, the gap reduced somewhat. And then down to an 18% lower rate of revascularisation compared to a person of the same age, sex, year of admission, AMI type, and admitted to the same hospital. So we're sort of comparing people admitted to the same hospital in the same region, and we still have a lower revascularisation rate. And then we adjusted for comorbidities, and that further reduced the gap, but it's debatable for some of these comorbidities, perhaps people with diabetes, with and without complications, they're likely to have more severe disease and in fact be more in need of a revascularisation procedure. So we've sort of adjusted away for that, but we're not quite sure if that is it's debatable whether that's the right thing to do. And then we sort of can eliminate the gap if we also adjust away for a person being a smoker, using alcohol or other drugs, and finally for having private health insurance, we can account for all the gaps. But it has prompted a lot of discussion about where the 24-hour cardiac catheterisation labs are placed in New South Wales, how far people are from those. So there's already some thinking about that and some attempts to make those more available in regional New South Wales to improve the chances of not just Aboriginal but other regional residents getting better access to cardiovascular procedures. So in summary, the overall work shows a range of issues. One about the young age at which Aboriginal people have experienced cardiovascular disease and have their first heart attack, which, as I said, was on average about 12 years younger than non-Aboriginal people, and a great disparity in younger people and amongst women. And it reinforces the importance of prevention and management of early heart disease symptoms. I've talked about cardiac procedures. Aboriginal people with an AMI less likely to get revascularisation. It's partly related to the hospital admission and the higher rate of comorbidities, but there is room for improvement, I'm sure. And then I didn't show you the mortality data, but we also found that there was no difference in the 30-day mortality after a heart attack for an Aboriginal person in New South Wales, but they did have a higher risk of death within the first year after that heart attack. And it may be related to the importance of follow-up care and possibly related to the lower procedure rate. So in terms of translation, lots of good things are happening. Some of this work around the development of essential service standards for equitable national cardiovascular care for Aboriginal and Torres Strait Islander people has been led by Alex Brown and initially fostered, I think, through the Cardiac Society of Australia and New Zealand. And that just doesn't focus on coronary artery disease, but heart failure, stroke, rheumatic heart disease and hypertension, systems of care and a system-based approach to reducing inequalities. And really, the Heart Foundation is up there they have 7 current priorities to champion efforts in this area, including crossing that whole range of prevention right through to cardiac rehabilitation and the patient journey post-cardiac events. So that was really the end of what I wanted to say, but it was mostly trying to reinforce some partly positive stories about terrific research that has been conducted in Australia over the last 30 years that has had a positive impact on Aboriginal people's health. So we shouldn't always be wringing our hands and thinking all is lost. It's such a bad news story. There are good news stories in there, but we still have work to be done. So I'm particularly interested in cardiovascular disease and breaking down the barriers and improving the outcomes for Aboriginal people in that area. Thank you.
Thank you very much, Sandra, and I think you'll agree that was an absolutely brilliant talk. Does anyone have any questions?
Thank you very much. That was really interesting and uplifting. It's very nice to hear positives. Is there any cultural reason that Aboriginal people would have about birth registrations? Is that an impediment to registration?
There's quite a lot of work being conducted by Monash University, not through their health faculty, but I think the legal aspect of birth registrations, and that's internationally why it's important, because it's the legal aspects of citizenship and the rights of citizenship. But part of the feedback and the questions I got was that it might be the stolen generations, a fear of having your baby identified. But I think looking at these data, it really clusters around 2 issues. That's remoteness and disadvantage. We did have a lot of trouble. We tried to get an Aboriginal person whose child wasn't registered to help with the media and sort of be a personal story that gave added impact to the story. And there was a lot of fear. No one would really say, they said, we don't want anybody, we don't sort of want to put our head up because that might increase the focus of welfare authorities on us. So there was definitely a fear of future removals if you fessed up to the fact that you hadn't registered your baby. But I'm not sure that it was, I can't really say whether, based on our data and what I know in the community, it's really a primary reason why people don't register their children.
Right at the back.
You seem to have started to focus on particular types of disease, like cardiovascular disease, and its relationship to remoteness or other factors. Do you think that, what's the advantage of doing that by particular disease as opposed to sort of focusing on maybe just the remoteness and the other factors? Like, what's the advantage of looking at individual diseases?
Well, I showed you a long list of conditions, including cataract surgery, ear surgery. I think using these data, some things are easier to look at than other things. It's very hard to look at diabetes because it's hard to work out when someone was first diagnosed with diabetes. So you'll notice, even though diabetes is a really important condition and it's big, the data are not, it's not easy to work out the incidence question, and then a whole lot of other things flow from that. So although it's big, major contributor to the gap in health status, we haven't looked at that. I suppose when we began, and the team who led this at UNSW began, we sort of began with big things that have a big impact on Aboriginal life expectancy, and heart disease and diabetes were up there. It's easier to look at procedures, and so I think for a range of reasons, the nature of what's reliable in the data, that drove, and the importance of the issue, that drove the original focus on cardiovascular disease. And so that's some of our oldest work, and we've worked through all the different parts of that. But really, there was a list of about 10 other different conditions and problems, including, I think another really interesting part of that work is the injury prevention work, which was really useful. And in some of the cases, procedures and care was actually more accessible in remote areas, and so cataract surgery. But you can, and so there were specific programs to promote and improve access to cataract surgery in regional and remote areas, and that came through in the mapping of the procedure rates for Aboriginal people who required cataract surgery. So it's partly, there wasn't, that was sort of the logic, and it's driven by the conditions themselves and what contributes to Aboriginal health and also quality of life. You know, cataract surgery is a quality of life question, but it was sort of as we worked through the data and got to them over time more than, and some things were reversed, like Aboriginal people having higher rates of cataract surgery in remote and regional areas than in urban areas.
Surely they would have identified that he was at high risk just by the fact that he is an Aboriginal man.
Well, I think what it's brought home to me is that there are a range of factors contributing to this. So I would have thought what you think. If an Aboriginal man comes in with chest pain, whether he comes to you as a GP, actually the third GP was very helpful. But GPs are very influenced by what the cardiologist said. So the first two GPs said, that's what the cardiologist has said, that's the right advice, that you've got coronary artery disease, but you can be medically managed. But he was telling a story of symptoms not settling even on treatment. And the third GP provided a referral to a tertiary care hospital, and he did get advice he would receive an appointment for an angiogram, but over 4 or 5 weeks. It didn't come on the back of a story of increasing symptoms. What I think is, it's economics and the ability to pay for healthcare is a large driver, regardless of, we think we have a universal healthcare system, but we do have inequality, and we have to find a way to grapple with that. The most recent Medical Journal of Australia edition has quite a few articles on cardiovascular care and in relation to people who live in regional areas and low socioeconomic areas. It didn't touch on the issues in relation to Aboriginal people. So there's an overlay. So there are economic drivers, and there are. I loved hearing this morning the presentations on cultural competence, because some of this is about cultural competence. So I'm almost 50, university educated, know the healthcare system but can advocate and understand how to navigate it. My brother is the oldest in our family. He's worked for the last 12 years in a very stressful, low-paid job, and he's not university educated. And he knows a lot about a lot of things, but he doesn't know much about how to navigate the healthcare system, and he wasn't really expecting to. And I think there's the culture. So there's issues in relation to health literacy and his ability to be Bolshian, navigate the healthcare system, but also cultural competency on the part of people assessing him and their ability to understand the statistics in relation to Aboriginal people and exercise a higher degree of caution in making clinical decisions, but also to interpret the slightly atypical story he was telling with acute coronary syndrome, where he was unstable and mostly saying he was short of breath and feeling faint, rather than when I take my bins out, I get crushing central chest pain. You know, red flag, everybody gets it. But when I take my bins out, or when I vacuum the floor, 5 weeks ago it was when I was playing football, but now it's when I'm vacuuming the floor. But, you know, for somebody who's a bit introverted, not compelling, bolshy, you know, not likely to say, on the occasion he went to the emergency department, I know you want me to go home and wait for an angiogram appointment, but I'm not going, because I'm not leaving this hospital until you admit me and I get an angiogram. So people are not, his health literacy, the cultural competency and the clinical judgment of people providing the care. But I've got to say, once he got his angiogram, he got terrific care. And and he's just been really happy. But I think he is an Aboriginal man in an age group where lots of the Aboriginal men he went to school with, who are grandfathers like him, they've dropped dead in front of ATMs. He's been to a funeral. So he's very aware from people his age dying around him, often from, but not always from, heart disease, about the risks once it was in the radar. But I think it's quite complicated. But I really love the presentations on cultural competence. I haven't been to a meeting where I've seen trainee health staff or health staff present on that. And the thing I really liked is Aboriginal people can't fix cultural competence in the healthcare system because we're not there providing the service. We can perhaps fix health literacy and front up to a hospital and be able to be more aware of what our health needs are, more able, if we're to make a decision to pay for private health insurance, if we're financially able to, more able to have the health literacy and access primary health care and manage compliance with, you know, blood pressure, cholesterol, you know, diabetes management. But we can't manage the cultural competence issues of providers in the healthcare system. So really, again, I can't say it enough. I love those presentations this morning. I know they're sort of preliminary work, but more needs to be done in that area, and not where we just dismiss it as, oh, that's the light and fluffy soft part of healthcare, because actually if you look at those case studies like the one of my brother, they really, you go to a hospital with chest pain, you got acute coronary syndrome, do they hear the story and assess you and say he's unstable, we'll admit him and do an angiogram, or he's stable enough, we'll send him home and we'll send him an appointment for an angiogram. So I think it's really complicated, and we're heading in the right direction, but much more needed to be done. And the whole other issue of financing procedures in the Australian healthcare system, and this is one of them, for Aboriginal people or poor people or people living a long way from services, requires a different set of fixes.
Just looking on the time. What time for one more question, if anyone's got one? All right, well, I think that's a signal for us to, we've got a gift for Sandra and also a gift for Sam, so I'll just ask Sandra to come up and
Thank you. And thank you again for the invite to the meeting.
Don't forget to come along to the poster session later this afternoon at 4:30. There's about 104 posters, so you'll need time to get around them. There will be some wine and canapes, and we'll look forward to seeing you there. But we do have another session this afternoon, and that will commence at around 2 o'clock. Now, I have just had a message telling me that there is no lunch here yet, but don't panic, as they say. Hopefully it will arrive soon, okay? Thank you, everybody.